So the next talk is by Dr. Wicklung from Gothenburg on benefits and risk of pre-transplant assist devices.
Dear moderators, ladies and gentlemen, many things has already been said about the benefits and risk for pre-transplant assist devices, so I may not say so much. But I'm coming from a different institution than, for example, Berlin and Bad Oeynhausen. But I'm also coming from the northern part of Europe, which means that we have our own allocation system. So what I'm saying now is not, you can't just say it will be the same in the rest of Europe, but it's kind of interesting. When I've heard about Berlin and the number of heart transplants is going down, we see that it's completely the opposite in our institution. The number of transplants is going up. This year I think we will come up to 35, maybe 40. And that means that the mechanical assist devices are going down, which is kind of interesting. But also that the technology has been an enormous development, and it doesn't make the life for us easier, it makes it more difficult. I would like to have this disposition of the talk. We'll talk about the short-term assist devices and the long-term assist devices, description, benefits and risks. We heard about the experience of the patient who had an LVAD and also an RVAD. An RVAD, short-term assist devices for 4 months. That's exactly what we are facing today. The short-term devices are so good today so that we can use them for long-term, which makes it more difficult. We are using short-term assist devices in the emergency situation. We're using it as LVAD, BVADs, ECMO, and I will say something about that. The LVAD and the RVAD is, I mean, we are all using the same. I mean, we're using the same equipment. It's just how we cannulate the patient, but we need to cannulate the patient open. It needs that we do a sternotomy. And what we have seen is that many of our patients today, they are coming from the cath lab. They have acute cardiac failure, and they may have gone through an PCI, but they are in a circulatory collapse. And that's why we today are using more and more percutaneously cannulation and that requires, of course, ECMO. And there are, of course, benefits with the short-term assist devices because we can save the patient. But it gives us time to evaluate recovery. We could check for comorbidities, which are contraindications for a transplantation or a long-term device. But there is also, of course, the possibility of to use a long-term assist device that may be the most common indication. As I said, that the technology has changed a lot the last 10 years. You can see on this slide how it looked 10 years, 15 years ago, and now we are waiting for this one, the cardio help, which it has been postponed all the time when it will be available, but we think it will be available this summer, next summer. Another thing which change everything is the outcome of the patient with ECMO, for example. This is the results from Karolinska and from our institution in Göteborg. We looked retrospectively on the outcome of the patients who were placed on ECMO, and half of the patients were placed in ECMO during CPR. And we were surprised when we saw the results. The patients who were not operated upon, the patient not from cardiac surgery, they had quite good results. And the results was also long-standing. So this surprised us a lot, that the results were so good that we could wean the patient, because most of these patients were weaned, not all of them. Some of them were transplanted, some of them got an LVAD. And when we looked at the patients who had acute myocardial infarction, the results were the same. But you still see that the patients who goes through cardiac surgery, the results are are not so good as many others have shown too. So what we have seen in our institution is a quite big dramatic change in the use of ECMO, and this year is even more. But of course there are risks with short-term assist devices. You have a risk of pulmonary edema if you do an percutaneous implantation or cannulation. Then you have the limb ischemia. You have to face that. It can be thrombus formation, emboli, infections, bleeding, etc., etc. But it costs a lot of money, because we see that these patients are taking more and more of the resources from other patients, which is okay today in our institution, because we today see the dramatic slowdown in other cardiac surgery. But it will be, of course, a problem. There is, of course, problems with organ allocation, ethics, and relatives. And we also know that from IHLT data that temporary circulatory support is a risk factor. And then it comes to the long-term assist devices, and we are using them in the non-emergency situation. And we have used them as LVAD, the BVAD, and the total artificial heart, even though we only have experience of 2 patients with the total artificial heart. We have been using this for more than 15 years. Some of these pumps we have been in an early phase with the Arvic 2000, for example, which gave us some problems which you have in the beginning of a program when the device is developed at the same time. We can face other problems. The ventral assist, as we heard, it's bankrupt. It's out of the market, which is also a problem for an institution like us, because we need the support from the company. We all need that. What happened when they go bankrupt? The total artificial heart, as I said, we have only had experience with 2 patients, and those patients went well, but they were very complicated. So they are both transplanted today and are doing well. But I think that total artificial heart is a challenge for a center like us. This is a slide just showing how complicated it is with the VAD. We can have bridge to transplant, bridge to recovery, destination therapy, and the patient can go from one to the other, can be transplanted, explanted, destination. We will all die. And we know today that the results after implants of long-term assist devices are quite good. This is the Intermax data, even though we should keep a little bit. I mean, the Intermax data are not. You can't transfer them to your own center. They are. Yeah, but you see that the results are quite good, and if you look at this slide, you can see after 6 months that 79% has either recovery, ongoing device support, or transplanted, and death 19% were dead, which means that this is a quite good results. So there is definitely benefits with it. You can stabilize the patient. You can reverse relative contraindications. And you can improve the status for the patient, which is very important, because when the patient is transplanted, that's the final operation, and the heart has to be there for a long time. This is in Ethiopia, when I was very close to an hippopotamus. So you see, I shot the picture myself. Some centers can show that they have the same results with LVAD as patients who are transplanted without LVADs. So there are some centers who can have the same results, but we don't see that in registries. We can also see that the improved quality of life, as in this slide, where you have some problems, extreme problems, and you can see that it goes down after the implants. But there are risks, of course, with long-term assist devices, thromboembolic, infections, bleeding, immunization. We saw that with the HeartMate 1, and economy, and the same here as we saw in the short-term assist devices. And as you know, we saw earlier that the results in patients with assist devices, if you look at the registry, is not as good as the patient is transplanted directly. There is also a difference between, this is data from the Intermax, the difference between LVADs and, as Gero said, the results with the total artificial heart is worse. So I also agree that we should avoid that if it's possible. Some centers have shown the same results in patients with acute myocardial infarction if they transplant the patient directly or they put them on a pump. The group 1 was patient had an LVAD before, and these patients were stable patients on the waiting list who needed LVAD. So in conclusion, assist devices can save lives. It makes organ allocation more complicated, and it's definitely associated with considerable morbidity and cost, are costly. Thank you very much.